first complaint would be swelling in the neck, nothing else. First chief complaint will be a swelling in the neck. So if we give you a case of thyroid, there will be a swelling, a visible swelling, a visible lump. Okay. Second would be, like I said, any other associated symptoms. That can be a dysphagia, or it can be a hoarseness of voice, or it can be a generalized hyperthyroid state, like he said, sweating, palpitations, and these things. Okay. So this is the chief complaint. So coming to the HOPI, history of present illness. So the patient was apparently well this many days back. Acha, remember one thing. Most of the surgical diseases of thyroid, say a colloid nodule, a colloid goiter, or say a Pap-CA thyroid, or whatever. These kind of diseases, surgical diseases, normally are asymptomatic at first. So incidentalomas are very common. You're doing investigations for something and you find out a thyroid swelling, thyroid nodule in there. Or another thing very common is patient suddenly noticed one day. Okay? Because this is not a symptom. কথাটা বুঝতে পেরেছিস? Patient most commonly হয় কি female patients who are dressing up or having a makeup in front of the mirror suddenly notices there is something odd in the neck. Or someone of the relatives say তোর গলায় কি এটা হয়েছে দেখ তোর ফোলা মতো লাগছে. So this is the most common presentation. So you try to write in this way. The patient was apparently doing well this many days back. She incidentally noticed a swelling involving left or right side of the neck. Okay. And then you mention the other things. Swelling is gradually increasing in size, say, or it is same as before, there is no progression of the size of the swelling. Any associated symptoms like dysphagia, dyspnea, stridor, hoarseness of voice, anything is there, you mention that. And then you also should mention any specific symptoms related to hypo or hyperthyroid state. Okay? To rule out any hypo or hypothyroid situation. Like you have to, by your history, by reading your history, I should be able to know whether I am dealing with a thyroiditis patient or a surgical thyroid nodule, maybe a surgery thyroid nodule or whatever, a colloid cyst or colloid goiter or something else. You should have your history written in that format. So, if we are looking into a hypothyroid patient, we should write the patient feels lethargic, okay, intolerant to cold. Heat intolerance is a hyperthyroid symptoms. Okay, or feels lazy and generalized weakness is there. Okay, all these kind of symptoms. Bradycardia patient to likhbi na. Bradycardia you don't write in HOPI because that's a finding that you will have. কথাটা বুঝতে পেরেছিস? A colloid nodule, a colloid cyst in the thyroid. 99.9% times euthyroid. Very rarely there will be hypothyroid symptoms. See, যত patient thyroid patient আমাদের কাছে আসে, if we, so what investigations, I'll come to the investigations later. I'll make you understand this. Just give me some time. I'll explain this to you. Okay. So HOPI, if there is an associated symptoms like I said, dysphagia or dyspnea or hoarseness of voice, we should also mention for how many days it is there. Okay. So pain, occasional pain in the thyroid, in the anterior aspect of the neck is quite common. But this signifies mostly কি করছিস রে? কি হলো, কি প্রবলেম? আচ্ছা আচ্ছা, ঠিক আছে, শুনতে পাচ্ছি। So any associated recurrent episodes of pain in the thyroid swelling, what that can indicate? Pressure symptoms will present as pressure symptoms. Pain, nerve, কোন nerve ওখানে pain হয়? That's an autonomic system. Hemorrhage, recurrent hemorrhages in the thyroid or acute thyroiditis. Okay, so see, thyroiditis patients, they usually have a waxing and waning course. Sometimes there will be inflammation, so patient will have pain, dysphagia, this stickiness in the throat and this kind of symptoms. Associated hyperthyroid symptoms like tremor, tachycardia, all these symptoms. And then again, after a few days, the patient will be fine. Okay, so it's always a waxing and a waning course. Okay, so this is your HOPI grossly. What negative history will you take? Very good. Anorexia, weight loss, fever, generalized fever or any associated fever. Sorry, generalized fever. Generalized fever. Fever, okay. And then, so usually, so what does this indicate? Anorexia, what does it indicate? Can be malignancy, can be hyperthyroidism. Hypothyroidism, ঠিক আছে? What? Fever, what does it indicate? শুনতে পাচ্ছি না। ইনফেকশন হতে পারে, হ্যাঁ ঠিক আছে। থাইরয়েডাইটিস can be associated with fever, any kind of infections, okay. And another is weight loss. Weight loss can be malignancy, hyperthyroidism. Hyperthyroidism is associated with weight loss. হাইপোতে মোটা হয়, মনে রাখবি। হাইপারথাইরয়েডে রোগা হয়, ঠিক আছে। And another thing you must, any other swelling in the neck. Examinationও লিখবি, HOPI তেও লিখবি, negative history তে। Patient does not complain of any other associated swelling in the neck. একটা লাইন লিখে দিবি, doesn't bother you much, কিন্তু it matters a lot. Okay? আর hoarseness of voice থাকলে we'll describe in details কবে থেকে শুরু হয়েছে, whether it is a persistent hoarseness or the voice improves off and on. Because two are completely different things. Say a malignancy invading the recurrent laryngeal nerve will have a persistent hoarseness of voice because the nerve is damaged. Okay, but an isolated vocal cord edema for a hypothyroid state will be waxing and waning. It will improve or it may deteriorate at times. Okay, so if there is hoarseness of voice associated, please check a detailed history of the hoarseness of voice. Okay. Then comes family history. Is very very important in thyroid. Why? Why? Well, family history can be important. কি বলি তুই? Men syndrome. Very good. So, some thyroid diseases are genetic. Okay, like the Men syndrome. Some thyroiditis have a genetic and a local preponderance. Like people residing in specific areas may have common presentations. Like I said, Hashimoto's thyroiditis, very common in the Sub-Himalayan region. Okay, so family history is important in thyroid. Very very important. Never forget family history in a thyroid swelling. Okay, medullary carcinoma thyroid is most commonly associated with a positive family history. Okay, and if there is a positive family history, take history of any other malignancies as well. Breast carcinoma. The common malignancies are ovarian CA. Okay, this can be, most female patients will be female. Thyroid, most thyroid patients will be female. Take history of these things. Okay, history of other malignancies in the family. Okay, so now coming to social history, smoking is not related to thyroid, but you should mention that in your social history, history, personal history, drug history. Drug history, how is very important? Drug history, why important? Any history of anti-thyroid drugs? ठीक है, for long term use. Patient হয়তো অনেক দিন ধরে is suffering from a hyperthyroid or hypothyroid state, taking medications for a long time. Okay, then you should mention the patient is on thyroxine or on say any anti-thyroid drug for this way. Carbimazole for methimazole, দেখো methimazole বেশি use হয় for this many days. You should write down. ঠিক আছে, now comes the most important part, examination. So your 90% of the thing will depend on this examination part in thyroid. ঠিক আছে, so first is inspection. A local examination I am not going. It is important, Because neck nodes are important. Pulse, BP, surface temperature, these things are important in thyroid. Okay, but you will anyways examine the patient in details and will know all these things. Don't forget pulse, BP, temperature, I mean the vital signs, neck nodes and thyroid. Okay, what is the special? Acha, I'll come to that. So examination means local examination. I'm talking of local examination. So we divide the local examination into inspection, palpation. See, percussion and auscultation are not there in the neck. Okay, inspection and palpation. So inspection, what will I write? How will I write? Site. See, your inspection finding and palpation finding may vary. That is the reason we do both of them, right? So inspection e chokhe dekhe idea ja hocche likhbi. No one can challenge you on that. Okay, it depends on a lot of things. You will tell the patient to extend the neck. You will inspect. So what will you write? A 2 into 2 centimeter or 2 into 3 centimeter swelling involving the left anterior neck or right anterior neck or midline anterior neck. What all things you will write? Size so bolli, size bolli. Any surface changes, any skin changes, huh? Movement with deglutition, lower border seen or not. Is there any retrosternal extension or not? Sometimes in thyroid we don't even get to see a swelling. See, many patients come with a USG report. কোথাও একটা দেখিয়েছে গ্রামে একটা USG report নিয়ে চলে এসেছে। এটা thyroid nodule, FNSA করেছে papillary CA thyroid. Okay, very common, young females, very common. খুব পাই আমরা। তো সেখানে ইন্সপেকশনে আমরা খালি দেখি বলতে is a diffuse fullness. So once you palpate, we can appreciate the okay. So here is the nodule and then we tell the patient to swallow and see the movement with deglutition. So inspection judge the finding, palpation is same points, but this time you are palpating. So one more point is surface, whether it is nodular or whether it is a smooth surface swelling. Margins, whether it is a diffuse margins or demarcated, clear and demarcated margins. Mobility and fixation to underlying structures. This thyroid gland is usually a fixed structure because it's enclosed by the pretracheal fascia, right? The capsule of the thyroid gland. Okay, so it's not freely mobile anyways. Okay, but a hard fixed thyroid, you will be able to feel it. হ্যাঁ সেটাই তো বলছি, সারফেস যখন তুই বললি it's a nodular surface, it's a multinodular surface লিখবি যদি it's more than one, and if it's a solitary thyroid nodule you will write there is a 2 or to 1 centimeter single nodule palpated on the left lobe involving the left lobe of the thyroid. Okay, it is soft to firm in consistency or it is firm to hard in consistency. Don't write hard unless it's a malignancy. I would prefer the term firm. Even if it's a malignancy, if you go with the term firm, it's okay. Okay, so firm is a safe term. Okay, আর যদি cystic হয় একদম তাহলে তো লিখবে 10 cystic swelling or a cystic lesion involving the you can feel it. It's a soft cystic lesion. Sometimes colloid goiters, colloid nodules are soft cystic lesions. ठीक है, तो involving this lobe, moving with deglutition, lower limit palpable or not, surface or margins, mobility, color করে দেখো, skin changes. Skin changes টা mostly inspection দিবি, palpation if you don't even give it's okay. And if fixity to skin তো তোরা you are already mentioning in the mobility. Any other lymph node involvement, palpation of neck nodes is a must for any thyroid swelling. If you don't do it, I'll reduce 50% of the marks. I myself will. আমি কেটে নেবো অর্ধেক মার্কস, যতই ভালো বাকি পরীক্ষা দাও। This is very important. Never forget palpation of nodules. So you should mention if there is any palpable nodes in the level. Thyroid কোথায় ড্রেন করে? 3A মারবো 3A টা আবার কি টার্মিনোলজি? নেক নোডস এর লেভেল জানিস তো তোরা? So commonest is level 6, pretracheal nodes, the central compartment nodes. Huh? Because that's a most common drainage area. Then it is level 3 to 4 or 3, 4, 2. So right lateral compartment of the neck. Level 2, 3, 4 most commonly involved. Sometimes if there is extensive disease, we have level 5 involvement. Second, 11 বছরের বাচ্চার প্যাপসিয়া থাইরয়েড করলাম, very bad disease, very extensive involvement trachea থেকে we have to shave off from the trachea. We'll need a high dose of radiardin post-op. Very sad. Whatever. তারপরে next palpation হয়ে গেল, and very important is any palpable pulsation on the thyroid. ठीक है? So these things we should mention. Okay, so now they will ask you what are the differential diagnosis. ठीक है? Oh, if there is a retrosternal extension, what will you find? Pressure symptoms or symptoms I'm also লিখছি. Lower limit you won't be able to palpate. So you can write there is a diffuse swelling involving the suprasternal area and lower limit not palpable even on extension. ঠিক আছে? তো usually এই কেসটা দেওয়া হবে না, retrosternal I think we will not give unless for spot cases and all, long কেসে দেওয়া হবে না কখনোই, বাট তাও বলে রাখছি বাই চান্স যদি। তারপর আর কি কি বল? Differential diagnosis. Differential diagnosis, what will be there? First is classify as benign or malignant. Okay. আচ্ছা আমাকে একটা জিনিস বল যে what are the findings that will make you think that this can be malignant? থাকতে পারে early thyroid malignancy may not always have weight loss. আচ্ছা associated symptoms এ আসি, thyroid gland examination এ তোরা কি কি বুঝবি? Irregular margins, okay, firm to hard inconsistency. ঠিক আছে? Progressively increasing in size, that comes in the history though, but then again progressive rapidly progressive size of Papsia thyroid, even see Papsia thyroid are very slow growing tumors. Usually এরকম ভাবে হুড় করে বেড়ে যায় সেটা হয় না, কিন্তু তাও very slow growing tumor. Palpation of neck nodes, then maybe regional metastasis to neck nodes. So palpable neck nodes is a very important sign that you are dealing with a malignant disease. And what are the other symptoms that you can have? Pressure symptoms, someone said. So it may be a malignant lesion which is compressing on the esophagus and the trachea. Okay, so there may be narrowing of the tracheal lumen, and can cause dysphagia if it is pushing on the esophagus. Right? Hoarseness of voice. A thyroid nodule associated with hoarseness of voice almost always is malignant. Almost always. Hoarseness of voice is actually a late presentation. Okay? Because the disease have involved the tracheoesophageal groove. There is extrathyroid extension. It has gone to the tracheoesophageal groove. There it has, most commonly it invades the nerve in the entry point, where it enters the cricothyroid joint. At that region is most common. Okay? Or, like I said, you are dealing with multiple nodes. Multiple palpable nodes in the neck is a sign that you are probably dealing with a malignancy. ठीक है? তারপর ডিফারেনশিয়াল ডায়াগনোসিস আর কি কি আসবে? এবার বিনাইন এর মধ্যে কি কি হতে পারে? মাল্টিনোডিউলার গয়টার, a colloid nodule, ঠিক আছে, a solitary thyroid nodule which is a benign solitary thyroid nodule. Okay, আর তারপর thyroglossalsis. How will you differentiate thyroglossalsis from thyroid? Thyroid হবে না? কেন? ট্র্যাকটা কোথা থেকে আসে? ট্র্যাকটা কোথা থেকে আসে? foramen cecum তলায় কোথায় লাগে উপরে তো base of the tongue foramen cecum তলায় কোথায় লাগে pyramidal lobe of thyroid so it will move why will not কে বলেছে মুভ করবে না so you have to understand the anatomy na it comes from the base of the tongue goes around the hyoid loops around the hyoid sometimes it can be retrohyoid it can be anterior to the hyoid as well in rare cases then it will come and up to the pyramidal lobe of the thyroid so if it is a patent thyroglossal duct or a thyroglossal cyst there will be movement so that is not a differentiating sign from thyroglossal cysts okay thyroglossal cyst will be definitely in the midline somewhere and thyroid swellings can be usually lateral to the midline don't say lateral neck it is lateral to the midline or on either side of the midline ঠিক আছে কিন্তু isthmus swelling হতেই পারে can be a thyroglossal cyst a swelling involving the thyroid isthmus can be a thyroglossal cyst as well okay it is a known entity okay what are the other disease all thyroiditis any thyroiditis can present as a thyroid swelling can be benign malignant can be hyperthyroid or hypothyroid based on the symptoms that you will have to decide as a malignancy what is the commonest malignancy of thyroid papillary carcinoma of thyroid papillary is not very common papillary thyroid carcinoma is the most common thyroid cancer okay what is the lateral aberrant thyroid so there are two major groups okay one is the differentiated thyroid cancers one is a undifferentiated thyroid cancers differentiated মধ্যে we get papillary follicular these are differentiated thyroid cancers because they are radioiodine avid they respond well to radioiodine treatment because they arise from the thyroid cells follicular cells medullary thyroid is a parafollicular C cell neoplasm so they are not radioiodine avid if it's a thyroid cell then only it will take up iodine na বুঝতে পারছিস because thyroid cells will need iodine for thyroxine then only it will take up iodine if it's a parafollicular cell it will not take up iodine so they are not radioiodine avid so treatment is much more difficult আমরা একটা পেপসি থাইরয়েড যেরকম ভাবে ট্রিট করি বা ল্যাটারাল নেকে প্রুভ ম্যালিগন্যান্সি নেই প্রুভ মেটাস্টাসিস নেই সেটা ল্যাটারাল নেক করব না রেডিওইডিন দেবে medullary carcinoma cannot do that the dictum is in medullary carcinoma you have to go for a total thyroidectomy bilateral neck dissection 2 to 5 in all cases because there is no other treatment the next form of treatment will be external beam radiation that is very toxic radioiodine is a very simple treatment cost effective very simple treatment ठीक है अच्छा और की theory अच्छा what is the treatment investigations and what is the management investigations and treatment so what investigations will we do the first when the patient comes to you in the outpatient department first is thyroid profile then ultrasound of the neck acha and then preferably a guided USG guided FNAC from the thyroid nodule so cytology imaging and blood hormonal levels three things mukhostor moto never forget these three things okay first write ultrasound for imaging okay and USG along with USG guided FNAC has a diagnostic sensitivity of over 90% okay there is a paper by from Tata Bombay very good paper so around 90 to 93% is the sensitivity rate so it's a very high sensitivity rate It's a guided FNSA. Okay. Then what all other investigations can we order? So I'm not going into routine blood and all those nonsense that you already know. Okay. So what are other specific investigations we may do? Ablation is a treatment. Radioiodine scan. Okay. What? How will it help you? I'll come to blood. Thyroid autoantibodies we may do to rule out other differential diagnosis. যেটা একটা থাইরয়েডাইটিসের পেশেন্ট কিনা, ঠিক আছে? দেন আর হ্যাঁ বল 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 সিসিটি আসছে, সিসিতে আসছি, তার আগে আগে এইগুলো বলে না। ব্লাডের তো একটা বললি হচ্ছে না টিটিপোটিএস হয়ে গেল, দেন থাইরয়েড অটো অ্যান্টিবডিজ এন্ড হি সেড ক্যালসিয়াম, very very important, calcium and vitamin D to rule out any parathyroid disease has been associated, or for calcium supplementation post surgery to know the baseline. Okay, that's important. Okay, so blood investigations, these all things will do. Imaging, what is radionuclide imaging? Technetium scan. Why will we not do a thyroid iodine scan? No, reactive iodine আমি কি দেখব না, what, how will it not help me in an intact thyroid? We do radioiodine scans, okay, but post-op. Why? Because the entire thyroid is radioiodine avid. So the entire thyroid gland will take up the iodine. How will it help me diagnose anything particular? কথাটা বুঝতে পারছিস? It's better if you have to do a radionuclide imaging, go for a technetium scan. It will tell me whether the nodule is hyperactive or a hypoactive nodule. Radioiodine scan pre-op will not help me much. যদি except is a large cyst, একটা বড় cyst আছে thyroid এ, সেটা uptake নিচ্ছে না, that is not a very common scenario. Either we can go for a technetium scan, technetium 99 scan, to see whether it's a cold nodule or a hot nodule. Chances of malignancy is more in cold nodules. Hot nodules or hyperactive or hyperthyroid state is less commonly associated with malignancies. Hypothyroid or a cold nodule, hypothyroid I won't say, a cold nodule is more commonly associated with. See, ধর এটা একটা ছোট্ট করে টেনে বুঝে নে, ধর এই পুরো থাইরয়েড গ্ল্যান্ডটা তো একটা নডিউল আছে, এবার নর্মাল লেভেল ধর থাইরয়েডের থাইরক্সিনের ধর x, ঠিক আছে? এবার এই নডিউলটা কত পার্সেন্ট, ধর খুবই ছোট কম্পেয়ার টু দ্য আদার থাইরয়েড এন্টার থাইরয়েড গ্ল্যান্ড। এবার ইফ দিস নডিউল ইজ হাইপার অ্যাক্টিভ, ইট ইজ আ হট নডিউল, কি হবে? ওভারঅল অ্যাক্টিভিটিটা প্লাস y হয়ে যাবে, ঠিক আছে? এবার ইট ইজ আ হাইপো অ্যাক্টিভ, the rest of the gland is large enough to compensate for this. So this y will be a small amount, and there will be increase in TSH and stuff, and so it will already compensate. কথাটা বুঝতে পেরেছিস? So having a hyperthyroid state is more common with smaller nodules than a hypothyroid state overall. Because if there is a hypothyroidism, the rest of the thyroid gland is big enough to compensate for the hormones. কিন্তু hyperthyroidism already ওই গ্ল্যান্ডটা তো নরমাল সেক্রেটই করছে, তার থেকে কিছুটা একটু বাড়লেই অনেকটা বেড়ে যাচ্ছে in the blood hormonal levels, ঠিক আছে? সেকেন্ড, এরপরে টেকনিশিয়ান স্ক্যান হলো CECT স্ক্যান. When we do a CECT scan, পর একজন বললি মেটাস্টেসিস, ওকে, রেট্রোস্টার্নাল এক্সটেনশন, ওকে, স্টেজিং একটু ম্যালিগন্যান্সি পেলে স্টেজিং কি আছে না ইউএসজি তে, মানে আসে কিন্তু আরো ভালো দেখতে আমরা সিটি স্ক্যান করাই, সেটা হচ্ছে মাল্টিপল নেক নোডস. ইফ দেয়ার ইজ আ নোডাল বার্ডেন, we usually go for a CECT scan, ঠিক আছে? Or if there is a gross extra thyroid extension, like if there is say a recurrent laryngeal nerve palsy, any alarming signs are there, dysphagia is there, dyspnea is there, or recurrent laryngeal nerve palsy is there, we need to go for a CT scan. Or if the ultrasound says that there are multiple nodes, even if you cannot palpate, it's safe to go for a CT scan to see the central compartment nodes, because they are not easily palpable. Suprasternal লস এখানে চলে যায়, ভালো করে palpate করা যায় না unless they are very big. ঠিক আছে? আর ইনভেস্টিগেশন আমাদের কিছু লাগে না। MRI rarely there is a tracheal involvement. There is involvement of the tracheal perichondrium to rule out any intertracheal mass in malignancy of thyroid. Sometimes we have to do a fiber optic bronchoscopy to see the trachea from inside. If there is a through and through intraluminal spread of the disease. ঠিক আছে? আর লাস্ট কি বাকি থাকছে? That is treatment. Treatment কি হবে? First we should make the patient euthyroid. Depends whether the patient is hyperthyroid or hypothyroid. ঠিক আছে? সব কি আমরা সার্জারি করব? সব thyroid nodule কি we go ahead with surgery? No. When do we go ahead with surgery? So see, for malignancy, any thyroid malignancy surgery, if there is a malignancy surgery, no doubt, whether it's a PAP CA, a follicular CA, or it's a medullary CA, whatever it is, surgery. Extent of surgery may vary. It may be a hemithyroid, it may be a total thyroid, it may be a thyroid with neck dissections, or retrosternal, whatever it is. Okay, but for benign, there are only very few indications of surgery. One is pressure symptoms. Pressure symptoms like dysphagia, dyspnea. Second is cosmetic purpose. If there is a large nodule in front of the neck and it doesn't look good, you may go ahead and do a surgery. And third is patient's wish. Very, very good. That is actually the most important wish. Most important, I'll say, indication of doing a surgery on benign thyroid. যতই ভাগিয়ে দিই পেশেন্ট আবার ফিরে আসে, না স্যার করেই দিন, ভয় লাগছে যদি ক্যান্সার আছে। And happens also. It's not like very uncommon. Many a times we get colloid nodules diagnosed Bethesda 2. You know Bethesda classification, right? Huh? What is Bethesda 4? এরকম ভাবে লেখা উচিত না, ওটা ইয়েতে রোমানে লেখা উচিত, বাট আমি তার জন্য লিখছি। So one is non-diagnostic, বুঝতেই পারছি না কি আছে না আছে। I don't know what it is. Either it's a acellular smear or whatever, is non-diagnostic. C is definitely malignancy. 5 is suspicious for malignancy. কি হলো? যত উপর দিকে যাবি তত খারাপ। ওকে, 2 is definitely benign. There is no sign of malignancy. So the problem is with 3 and 4. Probable area is 3 and 4. Okay, even in experienced hand, there is suspicious of malignancy, has a 90-95% chance of malignancy. So we take it as malignancy only. We treat it as malignancy only. 3 to 4. 3 is atypia of undetermined significance. There are some cellular atypia, but we cannot classify it as malignancy. And 4 is a completely different entity. 4 is any follicular neoplasm. Why? For follicular neoplasms, unless we do a histopathology, we cannot understand whether it's a malignancy or a benign disease. Because for follicular neoplasm, malignancy depends on capsular and vascular invasion. If there is capsular and vascular invasion, only then we can call it a follicular carcinoma. That we cannot see on FNAC, because in FNAC we take cells, we don't take tissue. বুঝতে পারছিস, আমরা FNAC যখন করছি we are taking cells, we are not taking tissue. It's a thin needle, so we can't know possibly whether there is any vascular or capsular invasion. So we call it a follicular neoplasm. Can be a carcinoma, can be a adenoma. ठीक है? Final, ये तो बात दी हमें. Level 4, Bethesda 4, you have to go for surgery, histopath. Sometimes we do a frozen section also. Frozen section is not very good level 4, but also जाना दरकार नहीं. We'll go for a histopath. If it's a malignancy, then we have to redo a surgery, doing a completion thyroidectomy, doing the other lobe as well. We preferably go for a hemithyroid if it's moderate in size or small in size. ठीक है? अच्छा. और hemithyroid और total thyroid कौन करबो? Any larger lesions, any মানে more than 4 centimeter in size, okay, with any alarming signs, total thyroid. Any neck nodes, total thyroid. Hemithyroid is only for smaller lesions, benign lesions. This much only you know. There are a lot of ifs and buts, ifs and buts, ifs and buts, but this much only you remember. Small lesions, no alarming signs, Bethesda 2, one benign on FNA and on an ultrasound. Ultrasound classification is called Thyroid's classification, but that's a long topic to discuss, big topic to discuss. So Bethesda 2, benign on ultrasound, smaller nodule, hemithyroid. Rest everything, total thyroid.